And thank you for sticking it out for the last of the scheduled presentations for the entire conference, actually, really. Today, our session is going to be, I should introduce myself. My name is Sean Cosgriff, and I get to be the moderator for this session. And today, we're going to be learning all about asparaginase. A couple of housekeeping things first. You can find the complete speaker bios in the HOPA conference app, and that we also ask you to hold all your questions until the end of the presentation. So it is my pleasure to introduce our faculty today, Joshua Elder. He is a clinical pharmacy specialist at Norton Children's Hospital. Please welcome Joshua.
Thank you, guys, and like you said, thanks for sticking around for the last talk of the conference. I know it's hard from being on the other side. So some learning objectives for today. We're going to review the role of asparaginase therapy in the treatment of acute leukemias. Asparaginase therapy really is the backbone, one of the backbones in pediatric leukemia treatment, and it's becoming increasingly more utilized in adolescent and young adult and adult leukemia protocols. We're going to discuss the adverse effect profile of asparaginase therapy and the major implications those adverse effects can have on treatment. And then finally, we're going to explain the utility of asparaginase monitoring in acute leukemias. And this topic's really picked up steam over the last several years due to the known importance of asparaginase in therapy. So quick show of hands just to get some demographic information from you guys in the audience. So first off, raise your hand if you primarily care for adult oncology patients. Okay, so the majority of you guys. In my practice, I regularly utilize asparaginase therapy, and we'll say regularly being over maybe 3 or 4 doses a month. Okay, still not as many, maybe a little less than half. And then I have utilized asparaginase therapeutic drug monitoring. Okay, not too many, maybe a fifth of you guys. So hopefully you guys will take something away from this. So first off, just to give you a background for why you have a pediatric person up here giving this talk, this picture really depicts all of the adult malignancy diagnoses each year. And if you look at those figures in the red, they really depict the adult leukemia diagnoses. So adult leukemias make up roughly 3% of adult oncology diagnoses. You compare that to pediatric leukemia distribution, and you get a huge uptick to 30% of total malignancies that are acute leukemias on the pediatric side. And when you look at that red bar of 30% of those patients, 85% of that red bar you can consider will be acute lymphoblastic leukemia, or ALL, where asparaginase is really a known standard backbone of those patients' therapies. So looking at asparaginase role in therapy, since we have several people in here who don't regularly utilize it and practice in adults, we'll briefly just review the mechanism of action. So asparaginase really has a fairly novel, slick mechanism of action. Asparaginase comes in, chews up the asparagine, breaks it down into aspartic acid and ammonia. And asparagine is an essential amino acid for leukemic cells. So by busting up that asparagine, you get cytotoxicity. But the great thing is that asparagine is a non-essential amino acid in healthy cells. So you really save a lot of those healthy cells from toxicity. So as I mentioned already, asparaginase products really are a mainstay of pediatric ALL protocols and are being utilized increasingly in the adolescent and young adult ALL populations. And I always like the slide because I always like to brag on pediatric ALL outcomes. If you really look at this survival curve, it's really nothing short of amazing and the progress we made in pediatric ALL over the last 50 years. So you can see in the late 60s, our long-term survival was less than 10%, and now we're all the way up to over 90% for long-term survival for a lot of our acute lymphoblastic leukemias. And asparaginase really accounts for a lot of that uptick in the late 70s and early 80s. I like this slide because it shows the importance of asparaginase in pediatric outcomes. If you look at this diagram, the x-axis is years from diagnosis, with the y-axis being percent of event-free survival. And this study specifically looked at response to asparaginase individually, and you could see that patients who had a good response to asparaginase therapy had a 91% long-term survival, whereas those patients who had a poor known response to asparaginase had definitely a worse outcome at 33%. So I want to talk briefly about the formulations, as formulations of asparaginase have definite implications on the efficacy, safety, and therapeutic drug monitoring that we employ with asparaginase products. So this first column is your E. coli asparaginase. Of note, this was a historical product. It's no longer around. It was DC'd in 2012. But just looking through some of the properties of E. coli asparaginase, the dosing was 25,000 units per meter squared with a relatively short half-life of 1.3 days. So E. coli asparaginase really paved the way for PEG asparagase to be developed, and this is the pegylated form of E. coli asparaginase, which greatly extended the half-life of the medication to about 6 days, and that really allowed us to replace several doses of E. coli asparaginase, 4 to 6 doses, all the way down to 1 dose of PEG asparagase. So you can see the duration of asparagine depletion and the peak asparaginase activity were significantly prolonged. When you look at the last column, Erwinia asparaginase, this is our most recent product that's FDA approved. Typical dosing is 25,000 international units per meter squared. And you can see, again, you're back to that short half-life, less than a day. So unfortunately, when patients don't tolerate PEG asparagase, you have to switch to Erwinia asparaginase, and it does take 6 doses to replace 1 dose of PEG asparagase. Just to give you an idea of one example of a PEG asparagase treatment example, so you can see this is just a quick snippet of a high-risk acute lymphoblastic leukemia protocol. So patients typically would receive 1 dose of PEG asparagase in induction. They would receive 2 doses in consolidation and 2 doses in delayed intensification. And again, if they have to switch therapy from PEG asparagase to Erwinia asparaginase, the conversion is 25,000 international units per meter squared for 6 doses to replace 1 dose of PEG asparagase. So to be inclusive and speak to all the adult people in the audience as well, obviously asparaginase isn't as big of a mainstay in therapy in the adult oncology protocols, but there are 5 studies that have current results in adult leukemia patients up front. And I don't want to focus on too much of this chart, but if you look, draw your attention to the asparaginase doses, you can really see a wide range of doses utilized in these 5 studies. And really that just goes to show that our optimal dose and schedule in adults is really unclear at this point, as is what dose, what age patients will tolerate this. We have thoughts that the older you get, obviously, the less likely you are to tolerate asparaginase, and that number seems to be, when you read in the literature, around 45 to 50 years of age at this point. And the other thing I'll draw your attention to is which product they used. You can see 4 of these 5 studies used E. coli asparaginase, which is no longer commercially available. So only 1 of these studies used PEG asparagase. So looking to the future, I think HOPA has really taken on to looking to the future with the whole theme of this conference. So we're going to talk about a couple of products, PEG chrysanthespase and L-asparaginase encapsulated within erythrocytes, which I'm going to refer to as GRASPA from now on. So when we think about our previous formulations that we have available and had available, E. coli asparaginase was our originator product. The natural progression was to pegylate that to make it easier for our patients, so we got PEG asparagase. We're left now with Erwinia asparaginase, and the natural progression would be to pegylate Erwinia asparaginase to replace those 6 doses with hopefully 1 dose of PEG chrysanthespase. So PEG chrysanthespase is pegylated Erwinia asparaginase. And some brief reports that have been published over the last couple of years. So we had our first snippet of what this drug would look like in clinical practice in phase 1 in 2014. This looked at 18 to 50-year-old adults with a median age of 40 years. They gave these patients doses anywhere from 500 to 750 international units per meter squared IV every 2 weeks for 10 doses, and 10 patients were included in the study. What they found were that this study, PEG chrysanthespase, was well tolerated with no reactions. So everybody was quite hopeful at this point, but I will say none of these patients had been exposed to PEG asparagase. So when we look at the COG snippet, or Children's Oncology Group, which is the largest clinical trial network for pediatric malignancies, they brought forth a phase 2 study a couple of years ago looking at PEG-crisantaspase. And to be eligible for that study, you had to have a grade 2 or greater hypersensitivity reaction to be eligible for PEG-crisantaspase. They included patients ages 1 to 21 years of age. There were 4 patients. And I know that sounds like not a lot, and we'll talk about why that's not a lot in just a second. But 750 to 1,000 international units per meter squared IV every 2 weeks for 2 doses. And what they found was that 3 of 4 patients developed hypersensitivity or rapid clearance. So that phase 2 study was actually put on halt. And we'll talk about, in some coming slides, more to come on the theories for why those patients had increased reactions. So the next product we'll talk about, which I would guess the majority of the audience is not super familiar with, is Graspa. Graspa is being studied primarily in Europe, although there are some centers that are starting to participate in the United States, to deplete asparagine over a longer period of time with lower doses, and hopefully you can tolerate the product better. So what happens with the mechanism of action is that asparaginase is actually pumped into these erythrocytes. So you can imagine the manufacturing process is not super easy. So this was done in Lyon, France. There was a specific laboratory that was pumping in asparaginase into the red blood cells. They did it over 3 hours. And that red blood cell protects the asparaginase from being broken down by antibodies. And it also allows it to have the same half-life as the red blood cell. So your half-life is extensive. The half-life is roughly 90 days, which you would think of with, or lifespan would be 90 days, the lifespan of a red blood cell. And hopefully these patients can tolerate it better. Obviously, too, since it's a blood product, they imported this asparaginase into the red blood cells, and then they had to do a quick turnaround time. So it was ABO matched compatible blood, and then they had to get that blood back into the patient within 24 hours. When looking at some of the results that have come out so far, our first phase 1/2 study was published in 2011. They looked at patients ages 1 to 55 years of age in their first relapse. They looked at a sample size of 18 patients at 3 different dosing schemas. They looked at doses of 50 international units per kilo, 100 international units per kilo, and 150 international units per kilo. Each patient got 2 doses, 1 dose in induction and 1 dose in consolidation. And they found that 1 dose of Graspa was equal to 8 doses of E. coli asparaginase. And when they looked at some safety parameters, they did note a reduction in allergic reactions. You have to take that with a bit of a grain of salt since these were just 18 patients. But no patients developed hypersensitivity, and they showed a trend towards less coagulopathy. No patients had thrombosis, but 3 patients did have coagulation factors depleted, either fibrinogen or antithrombin 3. All of the other adverse effects were noted to be roughly the same as the comparator products. When looking at the next study that came about by Hinault, Berger, and colleagues in 2015, this was a phase 2 study, and I think it's interesting the target population they looked at, because to me this is what Graspa seems like it's being developed for, those older patients who are less likely to tolerate asparaginase therapy so they can get some of the same benefits that our younger patients get. So they looked at patients aged 59 to 77. They looked at 30 patients, and again they did the same dosing schema of 50, 100, and 150 international units per kilo. And what they found was that those patients who were on the 100 unit per kilo dosing schema had an 85% target asparagine depletion. Compared that to 50 international units per kilo, which had no asparagine depletion, and the 150 international units per kilo had a 71% asparagine depletion. So what they've taken forward with their recommendations is to utilize a dosing of 100 international units per kilo. What they found was that they didn't have any patients who had allergic reactions or pancreatitis, although they did denote a 17% average increase in lipase, although that was found to be clinically insignificant. And they did note that 50% of patients were developing anti-asparaginase antibodies, but the whole point of Graspa is that it's protected. One of the points is that it's protected from those antibodies since it's encapsulated in red blood cells. So with all of that, GRASPA initially submitted for EMA approval in 2015. It got bounced back just because EMA wanted a little bit more data. And they have resubmitted for approval in Europe in October of 2017, and we're still pending a decision. I checked this morning. So that brings us to our first audience response question. HL is a 16-year-old with very high-risk ALL who has developed an allergic reaction to PEG asparagase after his second dose in therapy. Which therapy would replace his third dose of PEG asparagase? So is it A, E. coli asparaginase 6,000 international units per meter squared IV times 4, B, Erwinia asparaginase 25,000 international units per meter squared IV times 1, C, Erwinia asparaginase 25,000 international units per meter squared times 6, or D, PEG chrysanthus-based 7,500 international units per meter squared times 1. And I'll give you guys just a couple of minutes to respond. Okay. Perfect. So the correct answer is C. Remember, A is incorrect because E. coli is no longer commercially available. B is incorrect because it does take 6 doses of Erwinia asparaginase to replace 1 dose of PEG asparagase. C is correct, and D has not made it to market. They are kind of going back to the drawing board on the pegylated Erwinia asparaginase. So next we're going to focus on adverse effects of asparaginase therapy. And for all of the great therapeutic benefits asparaginase brings to the table, these therapies really can present some challenges for us. So the main adverse effects you would think about with asparaginase would be hypersensitivity, thrombosis, pancreatitis, and hepatotoxicity. And we're going to focus on 3 of these mainly, but obviously the toxicity profile of asparaginase products are more wide-reaching than these 4 adverse events, but these are the most common. One thing to note, if you develop a hypersensitivity to an asparaginase product, you are allowed to switch between products. So PEG asparagase is derived from E. coli. If you develop a hypersensitivity reaction, the whole point is to switch to Erwinia asparaginase because it's derived from chrysanthemums. So hopefully you'll avoid that allergic reaction. But it is important to note that if you develop something like a thrombosis or pancreatitis, you're done with all asparaginase therapy. So these drugs have up to a 35% incidence of reactions historically, so it's really important to know how reactions can alter therapy, and in the context of this talk and in the coming slides, how those reactions can affect your plan for monitoring. So here on the left side of this diagram, I have your common terminology criteria for adverse events, or CTCAE, definitions for grade 1 to 5 hypersensitivity reactions. You can see grade 1 is your less severe with transient flushing or rash and a drug fever greater than 38 degrees Celsius. And you obviously increase in severity all the way to hopefully never getting to a grade 5, which is death. So what happens when you develop hypersensitivity to these medications, or you develop antibodies to the drugs? You have your overt clinical hypersensitivity, but you also, those antibodies neutralize that drug, so you're not getting the therapeutic benefit of your drugs. Now, the scary part of this is there's this concept that's been introduced in the literature called silent inactivation, and that's when you develop antibodies to the drug, but you don't develop an overt clinical hypersensitivity. So in essence, your drug is not working, but you don't have any signs outward that your drug is not working. And we'll talk about this concept in a little bit as well. With all the hypersensitivity talk, I think it's important to look at timing of clinical hypersensitivity. This was a really nice paper published at the end of last year. It actually looked at 54,000 doses of PEG asparagase in 16,500 patients in 6 COG trials, and they looked at the 892 patients who had grade 3 or greater hypersensitivity reactions. So the things I just want to bring your attention to is you really don't expect an overt clinical hypersensitivity with your first dose. And anytime you're seeing that, it's definitely possible in the literature, but you should raise some red flags because it's most likely an allergic-like reaction, because more often than not, you need that immunizing dose to actually develop a clinical hypersensitivity. Far and away, most people developed a clinical hypersensitivity after doses 2 and 3, but once you get past those 2 doses, doesn't mean you're out of the woods, because it's still documented that you can develop a hypersensitivity after doses 4, 5, 6, or greater. So talking about the 6% of hypersensitivities that were shown with the first infusion. I think it's important to briefly bring up allergic-like versus allergic reactions because they really have implications on these patients' outcomes. They have huge financial implications if we get these decisions wrong and if we have to switch therapies unnecessarily. So let's just briefly go through these. And if you look at symptoms, so rash, pulmonary symptoms, cardiovascular, GI symptoms, you can see there's really not a statistically significant difference that you can make from allergic-like and allergic reactions. Where you really have to look, and this is a retrospective study of 28 patients who had reactions, is the timing of that allergic reaction. So allergic-like reactions aren't going to happen when that drug hits the body immediately. They're typically going to happen at a median time of 30 minutes into the infusion with a range of 12 to 47 minutes in this retrospective study that they showed. But if you have a true allergic reaction, that reaction is going to happen as soon as that drug hits the patient. So 2 minutes was the median time when you developed an allergic reaction with a range of 1 to 5 minutes, and that was statistically significant. The other thing you want to look at is anti-asparaginase antibodies. So if you have an allergic-like reaction, fairly a fake reaction, you're not developing antibodies more often than not, even though they did show one patient did develop antibodies. But if you have an allergic reaction, that's a slam dunk that you should have antibodies present. And again, it's a little unfortunate because we obviously can't immediately determine if we have antibodies present, but it's something to keep in mind. So allergic-like reactions truly can only be identified by measuring asparaginase activity. If tolerated, formulations should not be switched in case of an allergic-like reaction. Erwinia asparaginase is significantly more expensive than PEG asparagase, and it's not as convenient for patients because it's going to take 6 doses to replace 1. So your hospital management's not going to be super happy if you get this decision wrong and you're putting your patient unnecessarily on more expensive and more inconvenient therapies. And then finally, failure to recognize these reactions may lead to a less favorable prognosis. So if you're already on Erwinia asparaginase and you get an allergic-like versus an allergic reaction wrong, you're potentially taking away a really important therapy for someone who could benefit if they don't truly have an allergic reaction. So I just wanted to close up the hypersensitivity portion with looking at a couple of clinical controversies. So there's always been this thought of IV versus IM administration, what's better? So that same study that looked at the 54,000 PEG asparagase doses administered to 16,000 patients, of those patients who had a greater than or equal to grade 3 reaction, 5.4% had those reactions with IM administration versus 3.2% with IV administration, and that was statistically significant. That's quite convenient for us, obviously, because nobody wants to get stuck with a big needle IM, and it's just easier to give it IV. There's no such data that suggests the same principle applies with Erwinia asparaginase, and we'll talk about some other confounders with Erwinia later on. And then finally, hypersensitivity. I said we were going to come back to the PEG crisantaspase studies a little bit later. And is it hypersensitivity to the pegylation, or is it hypersensitivity to the asparaginase? So that first phase 1 study that looked at 10 patients, all of those adult patients tolerated it with no reactions, but they had never been exposed to PEG asparagase. The COG study had all of their patients recently exposed to PEG asparagase, and we saw that 3 of the first 4 of those patients reacted. And when they actually did some more digging into those 3 patients, they had all had PEG asparagase 1 to 6 weeks prior. And when they started checking some antibody levels, they saw that 3 of 3 patients did have anti-PEG IgG antibodies present, but none of those 3 patients had anti-Erwinia asparaginase antibodies present. So the running thought is most likely it's the pegylation that's causing the problem instead of the actually asparaginase product. So moving on, we'll talk briefly about thrombosis. We know having cancer alone gives our patients a higher risk of venous thromboembolism. VTEs can be precipitated by decrease in fibrinogen and decreases in antithrombin 3, and asparaginase is known to deplete those factors. And your nadir typically occurs 2 weeks into induction. So this is just a nice pictorial representation of that, and you can see on the x-axis the day in therapy. The y-axis has 2 parts. One side has your antithrombin level, the other side has your fibrinogen level. And you can see the dotted vertical line is where your asparaginase product is given, and about 2 weeks after that, you have your nadir in those 2 coagulation factors. It's previously been thought, especially in the adult population, that if you supplemented FFP or antithrombin 3, that you would be at lower likelihood to have thrombosis, but that theory has actually been disproven and shown that it may actually exacerbate the frequency. So we typically don't supplement fibrinogen or AT3, and we just typically don't check these levels. When looking at a couple of studies with actual thrombosis prevention with asparaginase, last year the Dana-Farber group published their results with a pediatric-inspired ALL protocol that just excluded Philadelphia-positive patients. It was an observational protocol. Patients were aged 18 to 50 years of age. 85 patients were in the sample. 36 of those received anticoagulation. 49 of them did not. And the patients who received anticoagulation got prophylactic anticoagulation with enoxaparin, either 30 milligrams BID, enoxaparin 40 milligrams daily, or dalteparin 5,000 units daily. They looked at as their primary outcome the incidence of VTE and the incidence of bleeding events. And what they found was that there was no significant difference in VTE, statistically significant. So 41% of patients in the control group developed a VTE, whereas 28% in the anticoagulation group developed a VTE. That had a p-value of 0.32. And they showed that there was no significant difference in bleeding. Actually, the control group who didn't have any anticoagulation had a 6% incidence of bleeding, and there were no bleeds in the prophylactic anticoagulation arm. So still lots of questions based on that study, and hopefully we're getting closer to this issue being put to bed. So there is a large-scale phase 3 trial going on through the Children's Oncology Group Network, ACCL 1333. It's looking at patients aged 1 to 18 years of age, looking at specifically during induction therapy when we know those patients are at highest risk for having a thrombosis. And those patients, based on their weight, are receiving apixaban, doses of 0.5 milligrams BID, all the way up to the adult prophylactic dose of 2.5 milligrams BID. And currently, they're looking at incidence of VTE and incidence of bleeding events, but that is still occurring, and I believe has a good ways to go before that trial is stopped. So next, we'll briefly touch on hepatotoxicity, incidence, and pathophysiology. Hepatotoxicity has the capacity to be very severe and cause death in our patients. Luckily, we don't see that commonly. Grade 3 and 4 incidence in pediatrics of hepatotoxicity is 5%, compared to grade 3 or 4 incidence in adults with asparaginase products being 14%. If you look in the literature, you'll see numbers of about 30 to 60% incidence of hepatotoxicity with asparaginase products, but luckily, not all of those hepatotoxicity cases are super severe, leading to significant outcomes for our patients. Typically, hepatotoxicity occurs 2 to 3 weeks after asparaginase therapy. And the proposed mechanism of action is depletion of asparagine and glutamine ultimately leads to mitochondrial beta oxidation impairment, which leads to fatty acid accumulation, which can ultimately lead to microvascular and macrovascular steatosis. Although this hasn't been well defined, this is the running theory. So there are 7 documented case studies of asparaginase-induced hepatotoxicity successfully being treated with levocarnitine at a dose of 50 milligrams per kilogram per day, plus or minus vitamin B complex. So vitamin B and L-carnitine really are important cofactors in mitochondrial beta oxidation. Carnitine aids in the transporting of long-chain fatty acids into the mitochondria, whereas components of vitamin B complex are precursors in beta oxidation pathways. So this is just a nice pictorial representation of one of these patients from a case report. So you can see essentially these figures say the same thing. One is looking at bilirubin levels before and after treatment, and one is looking at ALT and AST levels before and after. So you can see, again, these are just mirror images essentially, but just looking at different labs. Your first arrow pointing down is the first dose of asparaginase. Your second arrow is the second dose of asparaginase, and then once those numbers plateau, that's when treatment was commenced with levocarnitine and vitamin B complex And you can see the fourth arrow on the right side of each of those diagrams shows where another dose of peg asparagase was given successfully without incident. Just to give you some extra information on these case reports, 6 of the 7 patients did receive the same dose of levocarnitine. They all got 50 milligrams per kilogram per day. There was one outlier just based on that institution's experience, and they dosed super high at 450 milligrams per kilogram per day of levocarnitine. Everybody who got B complex got 1 to 2 tablets a day. So another hepatic toxicity that I just want to bring our attention to is hyperammonemia. And if you think back to the mechanism of action of the medication, so once we give asparaginase products, that asparagine is broken down to aspartic acid and ammonia. And there's definitely case reports in the literature of hyperammonemia. With asparaginase therapy, although the incidence and relevance really at this point is undefined. So when we think about symptoms of hyperammonemia, things we think about are anorexia, nausea, vomiting, headache, dizziness, and lethargy, and overall just encephalopathy, just like our cirrhotic patients in the adult setting. So there are, as I mentioned, several case reports available in the literature. Lactulose would be the treatment of choice, as outlined by some of those case reports, where you would trap that ammonium ion in the gut and also through the cathartic action of lactulose excrete that out to decrease your encephalopathy. There is thoughts that this is the rationale behind increased CINV with IV Erwinia asparaginase. I think we've all seen the questions on the listservs, at least in the pediatric families, that once you give IV Erwinia asparaginase, those patients just really have a lot of hard times with nausea and vomiting. So this would potentially make a mechanistic sense of why those patients are experiencing that toxicity. So I really want to close out this adverse effects section of the presentation, just looking at how the differences in large and small doses can affect adverse events that we're seeing in our patients. So we know we have increased toxicities once we have high doses of asparaginase. There is routine dose capping utilized with the majority of our adult colleagues in their protocols, looking at doses of 3750 international units, but we don't dose cap at all with pediatric oncology protocols. And there is a retrospective chart review of 183 pediatric patients ages 1 to 23 years of age, and that 183 included 159 patients who received less than 3750 international units and 24 patients who received greater than 3750. So what this case series showed is that there was a higher incidence of VTE at 20.8% versus 1.9% with those higher doses of asparaginase that was statistically significant. And there was a higher incidence of pancreatitis at 12.5% versus 1.9%, and a higher incidence of hyperglycemia at 25% versus 6.3%. So this really just shows that patients receiving more than 3750 international units of peg asparagase really should have increased monitoring for adverse effects, and that we really need to look at if we should be dose capping, especially on the pediatric side. And this is maybe another role for VTE prophylaxis and another argument for that, especially for our bigger doses. So with that, we'll have our next audience response question. So which of the following adverse effects has not been shown to occur at an increased incidence for patients receiving peg asparagase doses greater than 3750 international units? Is it A, hyperglycemia, B, hypersensitivity, C, pancreatitis, or D, thrombosis? Okay. And the correct answer is B, hypersensitivity, correct. All hypersensitivity, hyperglycemia, pancreatitis, and thrombosis in that retrospective series did show statistically significant increases when given with higher doses. So the next topic we're going to talk about is the utility of asparaginase drug monitoring, and this has really become such a big topic over the past 5 years due to the known importance of asparaginase in therapy. And we'll talk about the varying modalities studied to monitor asparaginase. So our 3 types of asparaginase monitoring, we know at this point we can look at asparagine levels. We know we can look at anti-asparaginase antibody levels, and we can also look at asparaginase activity levels. So we're briefly going to run through the pros and cons of each of these levels. When thinking about asparagine levels, the benefit is it really is the most direct assessment of depletion. However, we're limited by the fact that it is technically difficult to interpret. No one really knows what the true level of asparagine should be to clinically correlate with effectiveness. Anti-asparaginase antibody levels, again, the pros of this modality would be you could identify silent activation. You also could maybe identify your likelihood of an allergic reaction. The problem with anti-asparaginase antibody levels, though, is there's no commercially available assay, and they've been shown to have low specificity. When you look at nadir serum asparaginase activity levels, and I'll refer to this as just asparaginase activity levels for the rest of this talk, but this has best been shown to correlate with effectiveness. It's been shown to be reliable and reproducible, and we do have a couple of commercially available assays. And when I say asparaginase activity levels, the goal level we're looking for is greater than 0.1 international units per ml. So what's the current practice in pediatrics on our side? So asparaginase activity levels are commercially available via 2 laboratories. It used to just be 1, but we have another option now. It's Next Molecular Analytics or Granger Therapeutics, which used to be AI Biotech. Just to give you an example of cost, so these labs typically run around $700 now. When we first sent our asparaginase activity level, the first one 4 years ago, I think the cost was $55. So in 4 years, we've gone a bit exorbitant in our cost. There's probably an extreme wide variability in clinical practice. So I would say the majority of pediatric centers aren't checking levels on anyone. I would say there's a very select few centers who are checking levels on everyone. And I would say there's a few of us that are kind of in the middle, and this is where our institution lies, where we're checking with certain clinical criteria in certain situations. COG protocols, or Children's Oncology Group, was what the majority of pediatric institutions would participate in. Unfortunately, don't allow for dosage adjustments, and they strongly discourage pre-medication. So the problem with pre-medication is they don't want to mask a reaction, which obviously if you mask a reaction, your patients can potentially develop antibodies to negate the effects of the drug, and you might just not know it. And they don't allow dosage adjustments, so you really have to think from a financial standpoint, from an outcome standpoint, does checking a level do you any good? Because COG won't let you go up or down on your PEG asparagase dose. They force you to change to a significantly more expensive therapy in Arwinia asparaginase. And we already know our outcomes are over 90%. So there's lots of things that have to go into the decisions when you're checking these levels. Also, if you're already on Arwinia asparaginase, again, COG doesn't allow you to go up or down on your dose. There's no product you can switch off to. So you're going to have to make that decision. If you check a level and if it's less than the desired range, are you going to pull that kid off that entire study just for the ability to be able to go up or down on their dose? Are you going to ignore it, or is it best just not to know? So there's lots of things to think about when you think about these levels. So we've already spoken about the limited half-life of Arwinia asparaginase. 6 doses does replace 1 dose of PEG asparagase on a schedule of 25,000 international units per meter squared, Monday, Wednesday, Friday, times 6 doses. So this was a PK study looking at 48 and 72-hour asparaginase activity levels after IM or IV administration of Arwinia asparaginase. So what they found was when you gave this product via the IM route, 100% of the time you were meeting your goal level of being above that 0.1 international unit per ml at hour 48 and 72. And the 72 becomes relevant because you go from a Friday to a Monday between dose 3 and 4. They also looked at the percentage of patients with an asparaginase activity level of greater than 0.1 with IV administration, and they found definitely not as good of data. So 83%, which is still pretty good at 48 hours, but definitely 43% it had fallen off by hour 72. So pharmacokinetic data at this point does suggest that IM administration of Erwinia asparaginase is preferable over IV administration. I know this is a bit of a hot topic. For instance, at our institution, we've elected to stay away from IV administration, so we strongly prefer IM, and that's all we've given. And we've had discussions if a family does push very hard, we would do IV administration, but instead of doing the Monday, Wednesday, Friday, we would do a true Q48 hour times 6 to avoid that hour 72 being below goal range. So now it's time to start putting all this together with level monitoring. So in 2015, we had our first widespread publication on monitoring recommendations by Archie Blyer and our own Susanna Kuntz. So we'll walk through some different aspects of this monitoring algorithm. So we'll really focus on the right-hand side of this because the majority of your patients are going to get over 50% of their dose administered. You know, the majority of our patients do get all of their dose. And it was initially recommended that you would draw asparaginase activity levels 4 to 7 days after that dose. And if your level was less than 0.05, it was recommended to switch to Erwinia asparaginase because that was insinuating that you had a neutralizing antibody and you had silent inactivation. On the right-hand side, if your level was greater than 0.05, you continued on and drew another level in a week. Again, going back to the left-hand side in the pink, so if your level was at day 14 less than 0.025, again, recommendations to switch to Erwinia asparaginase because you're not meeting your targets. Compare that to the right-hand side of this algorithm, day 14, if you're greater than 0.1, you're all good. You continue your scheduled dose. And if you're somewhere in between, it requires a lot of finesse. It requires thinking about if your patient's on study, what are you allowed to do, what are you not allowed to do. So you probably should definitely continue monitoring. You can consider increasing your PEG asparagase dose, although COG studies do not allow you to do that. Or you could switch to Erwinia asparaginase, which COG does allow you to switch. So that's what we have so far for PEG asparagase. The Dana-Farber group has published an individualized dosing example for Erwinia asparaginase based off their own internal data, but just keep in mind that if you're a COG study, unfortunately, you can't really play by these rules if you have a kid on study. So looking at our asparaginase activity level, again, you want your goal to be above 0.1. They recommend no change. If your level's less than 0.1, they recommend increasing by different percentages. The thing that's interesting about their protocol is if you're well above the 0.1, so if you're 0.14 or greater, they recommend decreasing the dose, which is nice because there's thought that there's no additional benefit of being that super therapeutic, and you can potentially save some vials of Erwinia, save your money some institution, actually have enough Erwinia to give since it's on shortage half the time. But lots of things that you can consider with that, but again, we're limited. In 2016, we had our first consensus recommendations on what to do with asparaginase monitoring, and that was really broken up into 2 sections. So with silent inactivation, they recommended that all patients should have asparaginase activity levels monitored. For PEG asparagase, they recommended to monitor those levels 7 days after the first dose, and they defined silent inactivation as less than 0.1, and then they would recommend a switch or an increase in the dose. Erwinia, they recommended to monitor asparaginase and activity levels 48 hours after the dose and defined asparaginase activity below the lower limit of quantification, which is less than 0.02. And they recommended confirmatory type testing in all of these instances because this does have such a prognostic impact on our patients. In regards to clinical allergies, with grade 1 reactions and other questionable reactions, they recommended monitoring asparaginase activity level just to make sure your patients don't have true allergies so they're not developing those antibodies to the drug and negating the therapeutic benefits of that drug. If you have grade 2 to 4 reactions, it doesn't really matter because all the recommendations suggest that you should switch your patient to Erwinia asparaginase. So historically, silent inactivation has been reported in 25% of patients. And this is probably about to become much more convoluted in the next couple of years based on something that was published at ASH out of Emory a couple of months ago. And this was 221 patients reviewed at a single center. There were 96 eligible patients, and they had 260 asparaginase activity levels evaluated. And the really interesting thing that they found is that their levels range from 0.152 all the way up to 4.2. So nobody was really even being close to being subtherapeutic. So again, are we maybe overestimating what the silent inactivation prevalence is? I would love if somebody knows where this data is. I've looked far and wide to find where this historical number of 25% came from. I think it comes from straight lab data, and it doesn't come from patient data. So please stop me if you know where this is after this talk. So this is the current largest study that really shows no silent inactivation, which goes against some of the recommendations we've had over the last couple of years and some of our thought processes over the last couple of years. I'll tell you, this was discussed on the International Leukemia Call a couple of weeks ago. There's another center that is also going to be publishing pretty much the exact same results, 60 patients with only one patient having a level less than their goal range. So something to watch for in the literature through the rest of 2018 when this is actually published. And really this data changes the game. So we're going to have to start thinking about when you look at that first publication that had that dosing algorithm and the monitoring algorithm for PEG asparagase, we might be able to take a big chunk out of that algorithm with silent activation if it truly doesn't exist. This data fairly clearly points to the fact that probably we shouldn't be checking levels on everybody for silent inactivation, especially if our hands are tied in the midst of a protocol and we can't really do anything about it. But I think this does look at, when you look at the range of levels, 0.15 to 4.2, are our doses too high? Europe routinely uses lower doses, and these are incredibly expensive medications, and can we get away with significantly lower doses and still hit our targets of asparaginase activity levels being greater than 0.1? So just to round this out with kind of a pharmacoeconomic pearl, you obviously want to make sure all of the decisions you're making are economically feasible and sustainable. So the Dutch group looked at individualized dosing versus fixed dosing in two different protocols. And in their fixed dosing, they utilized doses of 2,500 units per meter squared, which is what we use in the US. In their individualized protocol, they looked at starting at a lower dose, which is more common in Europe, of 1,500 international units per meter squared, and they actually allowed you to adjust that dose up or down based on your levels to get your target. The cost for asparaginase dose, laboratory tests, and outpatient visits were all included, and what they noted was that there is a cost savings of 30.8% achieved with individualized dosing in ALL 11, which is what allowed for you to adjust your doses up or down. So with individualized dosing, they had 83 patients, total cost of $29,000, fixed dosing at $41,000. These numbers, to me, were really lower than I would expect based on our costs, but based on my research, it appears that asparaginase is a good bit cheaper on the European side. They did also not account for waste, although once they accounted for wasted vials, you still saved about $7,000 in this study, looking at individualized dosing compared to fixed dosing. And I think one thing that's really interesting is even though the Dutch group started at 1,500 international units per meter squared at PEG, if you look at the end results of their study, they were able to continue to adjust down their PEG doses to a medium of 750 international units per meter squared, which is roughly 3 times lower than what we're using here. So again, maybe huge cost implications as we go forward. So our last audience response question is, SL is an 8-year-old with ALL who has previously changed from PEG asparagase to Erwinia asparaginase based on clinical hypersensitivity. I will tell you he is not on study. A 48-hour post-dose asparaginase activity level was drawn and resulted at 0.08 international units per ml. What do you recommend to the team? Do you recommend to redraw the level as it should be drawn 4 to 7 days after a dose of Erwinia? Do you recommend to discontinue Erwinia as the patient's demonstrating silent inactivation? Would you recommend to continue the same dose as the level is within range? Or would you recommend to increase the Erwinia asparaginase dose by 20% to your target desired range? Okay, and the majority of you guys got it right. So the one thing that was tricky about option A is that would be a PEG asparagase recommendation of drawing 4 to 7 days after. With Erwinia, you draw a trough level at 48 hours. B, discontinue the Erwinia asparaginase dose as the patient's demonstrating silent inactivation. Not necessarily, and we definitely want our patients to get the therapeutic benefits of asparaginase therapy. Our level is below desired range, so we would want to bump up the dose with option D. So in summary, asparaginase therapy is paramount for achieving optimal outcomes in pediatric malignancies. I think we'll see definitely more to come from our adult colleagues in the coming years. And probably this talk can be repeated in a couple of years because I suspect we're probably opening Pandora's box if you've seen the article last month on asparagine and breast cancer being a driver of metastases. So maybe there's going to be a role of asparaginase therapy in solid tumors, especially breast cancer. And it was all over the nightly news, all over a lot of publications. So again, maybe look for that in a couple of years here. Asparaginase therapy is not without risk, and close monitoring is recommended to ensure safety. Remember, higher doses typically do equal more toxicity, although not more hypersensitivity. And remember, if you have a hypersensitivity reaction on PEG asparagase, you would switch that patient to Erwinia asparaginase. If you have other severe toxicities, you're done with asparaginase therapy, and that's not the intent of the Erwinia product. And then finally, asparaginase monitoring is readily available and essential to optimizing leukemia treatment outcomes. So you really have to be smart and judicious about this, and just because you can check levels doesn't mean it's a good idea to check levels. I think lots of institution-specific protocols, specific patient situations could drive your institution to very fairly do lots of different things. But from our approach, things that I believe you should do, you should definitely be checking asparaginase activity levels if you have a grade 1 reaction, because you want to make sure you don't have a true allergic reaction that's neutralizing the drug. If you're pre-medding your patients, probably a good idea for you to check levels because you don't want to mask hypersensitivity reactions and find out that your drug, you've spent all this money on this drug and it hasn't done any good. And then finally, cost savings. And I think that's going to be one of the most important things and one of the most unknown things going forward in the next few years. These doses of asparaginase we're using appear to be a lot higher than we actually need. And if you're at a center where your protocols allow you to adjust the doses, maybe you should be checking levels because maybe you can safely back down. Whereas if you're limited via certain studies, maybe it doesn't make as much sense to check levels right now for those instances. So thanks for hanging with me on the last talk. What questions can I answer for you guys? Yeah.
Great presentation. Thank you so much. My question for you is about the dose capping, especially in the pediatric setting. One of the studies you mentioned, or a lot of the studies mentioned the decrease in side effects, but did anybody look at efficacy? And what outcomes would we be needing to look at in the pediatric setting?
All right, so the question was about efficacy with dose capping. Nobody is looking at efficacy right now with that data. So I think it's going to be an interesting point going forward, and it's probably going to require a large-scale COG trial to make that decision. You would be hard-pressed, and it would probably be scary at your own institutions to start dose capping without a lot of wide information from across the country, because you don't want to be that one rogue center that maybe goes low. Exactly. Although it would stand to reason that we probably can and should go a lot lower, and hopefully we get there.
I know there's mutterings in COG that could come, but thank you.
Thanks. Yeah. Oh, hold on one second.
When you were describing the allergic-like reactions with the first dose, that sounds to me like what happens with Doxil, that CARPA, complement-mediated, which also looks incredibly like an allergy. Has anybody ever, and that's also a pegylated compound, has anybody ever tried to relate the two?
To my knowledge, nobody's tried to relate the doxo and asparaginase toxicities. I think we're getting closer in figuring it out. I think the hyperammonemia, we're probably really onto something, at least from an asparaginase component. But the pegylated component, I'm not sure we're there yet in knowing.
I'm just interested because that...
Absolutely.
Yeah. Okay, thank you.
Got another one.
Thank you so much. I have a couple questions, primarily because I work with adults.
Yeah.
So I see a lot of toxicities. So one of the questions I had is, do you routinely pre-med for this or no?
So we do not routinely pre-med. COG, we're a COG center, and they strongly discourage pre-meds.
Okay.
We've done it a couple of times and checked levels, but routinely we do not.
Okay, and then I have two more questions. My next one is, how quickly can you get back an asparaginase activity level?
So our experience is through AI Biotech, which is Granger now. We get them back within 24 hours. Now, I suspect if you send them close to the weekend, you might have a 2 to 3 hour delay. I've never really asked them about that, but they turn them around the next day for us.
Okay, and so I could use that level if, someone might have had an allergic reaction and then make a decision whether or not I will use Erwinia or just use the same product.
Yeah, and it depends on the type of reaction they have. If you get to the point where you have a greater than grade 2 reaction, you really should already be moving on to Erwinia. But if you do have that questionable grade 1 where you have just transient flushing or rash or a low grade fever, yeah, I would certainly check levels. And I think adults, you have the advantage too of not being confined to a lot of specific protocols. Mm-hmm. So I think the adults, in my opinion, should be routinely checking levels on asparaginase.
And then my last question, you didn't talk that much about, but just at your institution for AT3 repletion, how frequently do you monitor AT3, and what is your goal?
So this is very controversial at our institution right now. On the oncology side, I'll tell you we don't check it because we don't want to know. Because people tend to treat a number. If your patients are doing fine and the data we have shows that you don't need to replace and you get the same outcomes. Ask some of my ICU colleagues and you'll get different answers. But when we replace, we check AT3s more likely on our ICU consults when they're on heparin drips and such. I would prefer we replace to 60%, but I don't think I stand in the same ballpark as a lot of my colleagues.
Hi, thanks. It was a really good presentation. I'm a COG center also, and we don't do levels. I had a question about the hypersensitivity reaction, IM versus IV. Mm-hmm. So a few years back, we had a lot of reactions. We were giving it IM, and then we switched to IV, and we were infusing them over 2 hours instead of 1 hour. And we feel that there's less allergic reactions, but I've seen studies where some centers switched back to IM. So I was wondering what you were thinking about that, because I think your center does IV.
Yeah, so we do exclusively IV, PEG asparagase. We do opposite for Erwinia, exclusively IM. And we exclusively do 2 hours. I think it's all anecdotal with what we've seen around the country, but anytime you give asparaginase over 1 hour, I think you're setting yourself up for some really weird reactions and a lot of questions. Is this a hypersensitivity? Is this allergic-like reaction? And we mandate that all of our patients get over 2 hours, and we don't have to switch that often. We just don't have nearly the amount of problems that I've heard around the country.
But what would be the mechanism of action of what's the advantage of giving it over 2 hours versus 1 hour if you're going to have a true allergic reaction?
So if you're going to have a true reaction, I don't think there's an advantage at all, because if you're going to have a true reaction, you're just going to have it. I think the issue comes from the hyperammonemia, and the faster you give the medication, theoretically, you're going to break down asparagine to ammonia quicker, and you're going to get that surge, that hyperammonemia, which can look like funny reactions, nausea, vomiting, confusion.
Okay, thanks.
Any further questions?
Thanks, guys.
Thank you, Joshua.